had to make sure the video was ready. Okay, welcome everyone. Thanks for joining us tonight. Hopefully I've seen many of you before, I think, at the U.S. Center. If not, and this is your first time, thanks for joining us. This is our public outreach space for the U.S., and we've been doing this for 7 years now. And it's our attempt to bring climate science, climate information, and U.S. climate action to the world. So thanks for joining us. Thank you also for our online audience for joining us from all over the world. We appreciate your watching this event, and be sure to participate by using Twitter to hashtag AskUSCenter. My name's Ashley Allen, and I work for the State Department's Office of Climate Change, and I'll be our Master of Ceremonies for the event. We've got a nice, cozy group here, so for those of you in back, if you want to scoot in and be part of the conversation, please feel free to move up. That way it's going to be a little easier for you to ask your questions. This event is called Healthy People, Healthy Planet, and it's our only health-focused event, so you have a really unique opportunity here to explore a new issue. Before we dive into our panel for today, and before I introduce our moderator, we're going to first begin with a video statement by the United States Surgeon General, and the U.S. Surgeon General is basically America's doctor. So Surgeon General Vice Admiral Vivek Murthy, is going to join us right now with a video statement. Thank you.
I'm Dr. Vivek Murthy, the United States Surgeon General. As Surgeon General, my job is to provide the American public and our neighbors around the world with the best possible information to make good decisions about personal and public health. So let me be clear. Climate change poses a serious, immediate, and global threat to human health. It is a challenge so great that the responsibility for taking action to address it rests with every person, every community, every leader, and every government around the world. And let me be equally clear. The United States is taking action to address climate change and its implications for human health. And we want to build on the momentum from this meeting and from the critical steps so many in this room have taken to form new partnerships, new relationships with everyone assembled in Paris this week. That's because every living being is affected by the warming of our planet and by the increase in carbon pollution in our atmosphere. During this session, we'll hear about actions taken to address the risk climate change poses to our health facilities. We'll hear about work being done to raise the alarm when weather poses risks related to heat and infectious disease. And we'll hear about the nexus of climate change and clean air. But I want to begin by speaking for a moment about the stakes and what we risk through inaction. We all know of the global and national burden of asthma, allergies, and respiratory illness. We also know that climate change is lengthening pollen seasons and may lead to increases in asthma worsening air pollution. This means more clinic visits and hospital admissions, more days of school and work missed, and more health scares and consequences for patients and their families. We know that climate change means more severe extreme weather events, everything from hurricanes and wildfires to floods, which can take a toll on the physical and mental health of our communities. These events threaten our health infrastructure, leaving communities without access to necessary care. We know that changes in seasonal temperatures and precipitation affect the ranges of vector-borne diseases, such as Lyme disease, dengue fever, and malaria. And finally, we know that extreme heat, one of the most frequently experienced effects of climate change, affects us on a more regular basis, leaving people with a difficult choice of risking heat stroke and dehydration on the one hand, or curtailing their daily outdoor activities on the other. As with all of these issues, the burdens fall most heavily on those that are most vulnerable, our children, the elderly, and the poor. So inaction is unacceptable. We must act, and we are acting. To name just a couple of examples, President Obama and Prime Minister Modi of India have established a U.S.-India partnership for climate resilience. India has particularly highlighted health as a priority in their adaptation planning, and they have engaged with my colleagues at the U.S. Department of Health and Human Services to build capacity among Indian health professionals. And the United States and Canada are partnering to establish 7 regional research and training centers called Global Environmental and Occupational Health Hubs. With the support of scientists from the U.S. Department of Health and Human Services, these hubs will link to a new coalition of WHO collaborating centers to facilitate climate and health training and capacity building in the low and middle income countries around the world. I support these efforts at the highest levels of government around the world and at critical meetings like this one, because climate change is one of the key public health challenges of our time. With so much at stake, all of us share a responsibility to do what we can, as much as we can, for as long as we can. Thank you.
Thank you. Our message from the U.S. Surgeon General. Now I'd like to introduce to you our moderator for the event, and he will give you a sense of how the event's going to go and introduce you to our panelists. I'm pleased to invite Ambassador Jim Kolker up on stage. He is the Assistant Secretary for Global Affairs at the U.S. Department of Health and Human Services, and he is essentially the Chief U.S. Health Diplomat. Mr. Kolker.
Thanks very much, Ashley, and thanks to the Department of State for organizing something that really should not be the only event about health and climate change, because this is an important relationship. As we just heard from Surgeon General Vivek Murthy, climate change is an immediate and serious threat to public health. And increased severity and duration of heat waves will cause heat stroke and exacerbate other chronic diseases. Worsened air quality means increased respiratory and cardiovascular disease. Extreme weather events will cause injuries and premature deaths. And climate, as he said, affects our personal health, but especially the vulnerability already at risk from social factors, and it impedes our ability in communities and in our health systems to cope with health challenges. Our best estimate is that already foreseen climate change will result in 250,000 additional premature deaths per year in the years 2030 to 2050. To put that in perspective, we have projections that even more premature deaths could be avoided by reducing sugar and sodium content in processed foods, by having people stop smoking, by improving traffic safety. But that's just the point. All of these and many more serious illnesses are avoidable if we understand and take measures to prevent them. Just as we need to up our game to address communicable and non-communicable diseases, climate has to be in that equation. Hotter and wetter climate is helping to establish vector-borne pathogens in the United States and in other temperate zones, chikungunya, Chagas, dengue, that had previously been seen only in travelers from tropical regions. And the risks posed by outbreaks of novel infectious diseases are not new, but they're intensifying. Our ability to predict, detect, and respond to these pathogens requires a global multi-sectoral mobilization. And as we saw during the Ebola outbreak, there are far too many weak links and gaps in our capacity to do just this kind of mobilization and collaboration. Once an outbreak crosses a tipping point, our ability to control it's much more difficult. And with climatic factors, that evolution of an outbreak may be subtle and therefore missed altogether, or we miss key opportunities for interventions. Our health sectors need to take heed of these changes, to prepare for them, and to work across disciplines to avert or minimize negative consequences. We're very pleased that the United States, through the types of partnerships and initiatives you'll hear about today, is supporting the health sector in the US and around the world to bolster its sustainability and climate resilience. We've been raising awareness of the health implications of climate change, and we're taking action through national, bilateral, regional, and global platforms to foster relationships between the health and environment sectors. It's critical to engage health ministries and institutions working on health in mitigation, in preparedness, and in adaptation on climate change. Policymakers in the health sector need to know the implications of climate change and need to share options for bolstering resilience and highlight the benefits of reducing consumption of the very same fuels that emit greenhouse gases, both for our climate and for our health. At the department where I work, Health and Human Services, we're prioritizing implementing sustainable operations ourselves, promoting climate-resilient health and human services, supporting scientific research focused on the effects of climate change on human health, and as well as general well-being, and our National Institute of Environmental Health Sciences with EPA partners are supporting work to better understand the co-benefits that arise from taking climate action. So today we'll highlight 3 examples of American government activities, leadership, and partnership to prepare for and reduce the health risks posed by climate change. Our presenters will discuss first, healthcare facility resilience, second, climate services and using data for health early warning systems, and finally, the co-benefits of taking action to mitigate climate change. We'll have time for questions at the end of these sessions, and it's now my privilege to welcome Dr. John Balbus to lead our first discussion. John leads the National Institute of Environmental Health Sciences efforts on climate change and human health. He serves as the HHS principal, the U.S. Global Change Research Program, and co-lead of the Interagency Working Group on Climate and Health. John will also be joined by the former Chief Executive Officer of Gunderson Health Systems, Dr. Jeffrey Thompson. John, Jeffrey, welcome.
Thank you very much, Ambassador Kolker, for that introduction. And good evening to everybody in the room, and good afternoon to those of you who are watching us in the United States or wherever you are around the world. Good day in whatever time it is. Healthcare facilities are some of our most critical and most vulnerable institutions, whether we're talking about the United States or really any country. In the United States, Hurricane Katrina and Superstorm Sandy have been just the most recent examples of how, with tragic clarity, even in a high-income country, healthcare facilities can be vulnerable to damage and even closure from extreme weather events. And when hospitals and nursing homes close, people suffer. Whether we're talking about injuries and deaths sustained during evacuations to the untreated medical conditions that happen from lack of access to care, the health toll from these events and the others like them have been significant in the United States and in other countries. And with climate change models projecting stronger storms in many regions and increasing the amount of flooding and storm surge that's associated with extreme weather, the threats to healthcare facilities are greater than ever. And so we must make them more resilient. In recognition of this need, the U.S. Department of Health and Human Services has developed the Sustainable and Climate Resilient Healthcare Facilities Initiative as part of President Obama's Climate Adaptation Plan. Working with leading healthcare systems and the non-governmental organization Healthcare Without Harm, the initiative has provided comprehensive information resources, checklists, and other kinds of resources online so that healthcare facilities can get the information they need to assess their own strengths and weaknesses and identify the steps they need to enhance their resilience and sustainability. These resources were rolled out over the past year and can now be found on the White House's Climate Resilience Toolkit website, which is toolkit.climate.gov, if anybody's sitting at a computer now. We're working in a partnership with the Healthcare Climate Council, which is a set of leading healthcare systems organized by Healthcare Without Harm, to pilot the toolkit now, so that we can make it work for the health sector in the U.S. and become what we hope is a pragmatic and effective way to shore up the healthcare sector in the face of climate change and to protect the health of our residents. We also see this toolkit as being integral to our efforts to address climate and health changes more broadly. Through the WHO Collaborating Center at the National Institute of Environmental Health Sciences, where I work, we're also collaborating with the World Health Organization and countries around the world to share our best approaches towards healthcare facility resilience and identify the best practices for these initiatives. Along with the Pan American Health Organization, we met last September with participants from all around the Americas, including Canada, to hear about approaches that are being taken and to hear case studies throughout the Americas and determine ways to make all of our efforts that are going on in each of these countries, in each of these institutions, that much more effective. We have a report that's come out of that workshop. It's online now, and we're looking to take these best practices and to coordinate them around the world. So with me here today, and let me just, well, we have a clicker that isn't advancing the slides, so we've been watching the same slides. Now it's going. Let me advance to through this wonderful set of pictures that I thought was backing up my talk to our URL so that you can see where the toolkit resides. So for the rest of our time this evening, I'd like to discuss the topic further with Dr. Jeffrey Thompson, who's the former Chief Executive Officer for the Gunderson Health System based in La Crosse, Wisconsin. So, Dr. Thompson, tell us a little bit about Gunderson. Gunderson's a health system that has really led the way in terms of sustainability for healthcare facilities. Tell us about the kind of investments you've been making for the past decade.
Well, thanks, John. Gunderson and its board took a hard look at what we were doing. We're a good-sized organization, 6 hospitals, 60 clinics spread across Wisconsin, Minnesota, and Iowa, and said, we're supposed to keep people healthy. Our purpose is to improve the health and well-being of patients and our communities. And our energy supply was not doing that. We were putting millions, tens of millions, maybe 100 million pounds of CO2 into the atmosphere each year, and 460,000 pounds of particulate matter, like the Secretary's speaking about. This is an asthmatic producing activity. We said that's not good for a healthcare organization. So we took on the issue of first conservation. We reduced over the next number of years, we started in 2008 or 9, reduced our energy needs by 30 to 40%, and then started producing green energy on our own, because we wanted to not only reduce our impact, but we wanted to lower the cost of care and improve the local economy. We rejected the idea that it's the environment or the economy. We believed we could do all three, and we have.
Great. Tell me a little bit more about this. The healthcare sector is one of the fastest growing in our country. It's responsible for about $3 trillion of economic activity every year, but it hasn't been one of the first to embrace sustainability and think about climate change. Can you tell me a little bit about how you were able to work with your board and convince them that this was something important for a healthcare organization?
Well, I think a couple major things. One was that we started early with conservation and showed that not only could we reduce our impact on the environment and improve potentially the breathing of our asthmatics and COPD patients, heart patients that we're supposed to keep healthy, but we also joined a large group of healthcare organizations through Practice Green Health, the Healthy Hospital Initiative, that went from just a dozen of us to now 1,500 across the United States that are working on sometimes many, sometimes a few aspects. So this combination of many others showing the way, as well as us getting some early wins, allowed our board and our community to have confidence. And then we had partners from the state, the government, the local governments, the federal government, as well as private sector. So these partnerships, along with measuring hard and proving that we could lower our impact. And now we have probably an 80% decrease in CO2 production, over 70% decrease in particulate matter that we had talked about, a marked decrease, maybe a 20-fold decrease in hazardous pharmaceutical waste production. So by measuring hard and showing that you can make a difference and save money doing it, our board became confident that this is a great direction to lead in.
Thank you. So you've articulated very well how the sustainability agenda fits in with the business practice of the healthcare institution. One of the things we've been very explicit to do is to combine the idea that a sustainable and a energy efficient healthcare facility is also a climate resilient and a less vulnerable facility. Could you talk a little bit about how Gunderson is blending sustainability and climate resilience, and the extent to which the toolkit that we've developed is a useful tool for the kind of goals that you're setting for yourselves?
Yeah, I think it's very important to look at those as kind of overlapping circles, that there's an opportunity there just right out of the blocks. I talked about becoming more energy efficient. That decreases your load in the case of a crisis, that you can still operate and function. Your critical areas, hospitals, are one of the key pieces of keeping communities well in the face of a crisis. So having that ability to keep going is very important. The toolkit allowed us to examine all parts of our organization way beyond just the energy piece or the waste piece that I had talked about, look much more broadly at it. It also provides an avenue into best practices, other places in the country that are doing good things. We all have different climate challenges that are going to face us and different severe weather challenges. So it's important to look at your own area, and the toolkit has the breadth to give people across the country that opportunity to look at how they can best prepare for problems down the road.
Great. Thank you very much. So my final question for you before we leave the stage. The toolkit has been developed for a U.S. audience,
Yes.
and you know, you're one of the leaders in the United States, but obviously this is an issue that affects healthcare
Sure.
facilities around the world, and in different ways in different parts of the world. What are your thoughts about how healthcare facility systems or healthcare organizations like yourself and your colleagues and the activities of the U.S. government might be able to help sustainability and climate resilience of healthcare facilities around the world?
I think the first thing is they should understand that it's possible and be inspired, not just by Gunderson, but there are many, many organizations in the U.S. and across the globe that are taking on this issue and saying, yes, we can improve our environmental footprint and help the economy of the local region. So this very thoughtful approach to that. The U.S. government, Healthcare Without Harm, the Global Green and Healthy Hospital Initiative, the Healthy Hospital Initiative, there's many free resources that can look at various opportunities that have proven to be successful in different settings. So I think connecting those dots is easier than it's ever been before, and the evidence that it can be done should bolster those who firmly believe that it needs to be done. That's how we can all tie together and make it better.
Great. Well, thank you very much. You've set an agenda for our work in the coming future. Thank you for all the wonderful work that you've done at Gunderson.
Thanks.
And we'll now turn it back to Ambassador Kolker and look forward to the questions at
Add
the
my
end.
thanks to Drs. Balbus Thompson and learning about how the health system can actually be a contributor to the results we want, not just for health, but for climate as well. The next presenter is on video. It's the NOAA Chief Scientist, Rick Spinrad. Rick is the Senior Scientist for NOAA, driving policy and program direction for science and technology priorities. He'll share the NOAA's work in providing better climate services to inform public health preparedness and response.
Thank you for allowing me to join you today. Coming from the U.S. National Oceanic and Atmospheric Administration, and more broadly, the climate and weather community, our role is to produce and deliver timely, actionable, and reliable science-based environmental information that gives us the insight and foresight we need to make climate-smart decisions. In the public health arena, this means we work side by side with our partners to develop and deliver climate and weather information useful for assessing and managing risks to human health and safety. NOAA's work spans a spectrum of climate-related health risk factors and conditions, ranging from heat and air quality to waterborne, vector-borne, and other emerging infectious diseases. As an agency, we monitor and observe climate, weather, and ocean and coastal systems. We provide free and open access to those data. We archive data on behalf of other countries and international organizations, such as the World Meteorological Organization. And we conduct research and develop models to predict across scales of space and the weather to climate continuum for use in multiple sectors, including health. We are fundamentally a science-based services agency. NOAA is very much a part of the larger scientific community that seeks to understand and predict the Earth system. Our niche in the federal government is practical prediction, but our work doesn't stop there. To ensure we develop the most effective information for protecting public health, we work closely with our federal, state, local, and international partners. We engage with decision makers from the beginning so that public health managers are working alongside climatologists, data managers, and policymakers. We also collaborate on research that focuses on how people use and respond to climate and weather forecasts and other environmental information. This research is critical for making tools useful to practitioners. Many countries face similar challenges. We value cooperating with international partners and organizations and learning from one another. NOAA is one of the founding members of the Group on Earth Observations, and we support implementation of the global framework on climate services and are active in addressing areas of human health. As we look to current and future challenges to human health, public health decision makers need robust, sustained, integrated information systems. I also would argue these systems are gateways for continuously improving our research, observations, and prediction capabilities. How will these integrated information systems help public health practitioners and resource managers prepare for what's ahead? As heat waves become longer, more frequent, and more intense in the United States and globally, the right information at the right scales far enough in advance, along with the right tools, can help us prepare and save lives. So NOAA and the U.S. Centers for Disease Control and Prevention are building a national integrated heat health information system. The system integrates demands and stakeholder needs in a region with science and decision-making tools and decision support. We're also working with partners, Germany, India, the WMO, the Natural Resources Defense Council, to name a few, to make this U.S.-focused tool more globally applicable. Through pilot projects at city and regional scales, we and our U.S. and international partners are addressing key questions, like what should be predicted at what timescales, and who needs what kinds of information. How far in advance do they need it? Are we adequately addressing the needs of the urban poor or outdoor workers? Are we taking into account large public gatherings? Are we managing surge capacity at clinics and healthcare facilities in affected areas? India, with whom we have a heat health partnership, already has a heat action plan for Ahmedabad and is looking to expand the plan to other cities and regions. Cholera is another major focus for an integrated information system. Cholera is caused by outbreaks of waterborne bacteria known as Vibrios, which are highly sensitive to sea surface temperature, rainfall, and other environmental factors. Thanks to research funded by NOAA, NIH, and others, we know that cholera outbreaks occur when poor water and sanitation systems intersect with Vibrios. So we are working with the World Health Organization to build an integrated information system for waterborne diseases like cholera. Our first pilot in Bangladesh, being planned right now, is quickly becoming the backbone of a much larger Bangladeshi development agenda. For some time now, NOAA's International Desk of the National Weather Service has helped build capacity for meteorologists around the world. Here, you see our Climate Prediction Center's African Desk Coordinator, staff, and trainees in a climate discussion. We have trained climate and health professionals from sub-Saharan Africa who return to their countries better equipped to develop seasonal and longer-term predictions in their regions. In short, these integrated information systems and capacity-building efforts are about protecting human health from Dallas to Dakar to Dhaka. We need the right information far enough in advance and at the right scales, along with the right tools to help every nation, everywhere, prepare for the anticipated risks and to protect human health and human life. The U.S. and partners across the globe are working proactively and constructively to accomplish this. These systems are, by definition, partnerships that thrive on collaboration and cooperation. But our work is just beginning. We hope to see integrated health information systems grow in capability and number in the near future. The need is now, it is urgent, and it can save lives. I ask you to join us in a shared vision of healthy people and a healthy planet. Thank you to the State Department for convening us here today at the U.S. Center, and thank you to my HHS, EPA, State Department colleagues who have partnered with us. Thank you very much.
Thanks. That was Dr. Rick Spinrad, the Chief Scientist of the National Oceanic and Atmospheric Administration. I don't know if he realized it, but NOAA has just encapsulated what health diplomacy is all about, which is how to use data and evidence to change health and other economic and political policies and practices. And I think using the kind of database that they're developing will go a long way to help us anticipate as well as react to health impact of climate change. We're especially pleased to have here the Deputy Special Envoy for Climate Change, Karen Florini, from the U.S. Department of State. She's going to discuss linkages between climate change and clean air, which we increasingly recognize as one of the critical factors determining cardiovascular and pulmonary health outcomes, as well as things like asthma that you've heard about worldwide. Karen.
Thank you very much. As most of you know, carbon dioxide is the biggest climate pollutant, but it's not the only one. Others include black carbon and methane. These substances turn out to have a couple of important things in common. One is that they're removed from the atmosphere far more quickly than carbon dioxide. So they tend to be called short-term or short-lived climate pollutants, or SLCPs. The other feature is that black carbon and methane have in common is that both of them have significant impacts not only on climate, but also on health. Black carbon, which is essentially also known as soot, is a compound of fine particulate matter, which is usually abbreviated as PM2.5. Methane leads to formation of ground-level ozone. Okay, we're again having problems with the clicker, so I may not be able to show you our pretty pictures. Okay, good. So both of these substances, both methane and black carbon, are associated with a number of health problems, including cardiovascular and respiratory impacts, also known as your heart and your lungs. So reducing emissions of these compounds is a very important task. In fact, it's estimated that substantially reducing these compounds could prevent many of the 2.4 million deaths annually that occur from outdoor air pollution and of the 4.3 million that occur from indoor air pollution. So air pollution and climate change and health outcomes are very closely linked. But before I turn to my main focus, I want to highlight a step that the U.S. is taking to protect the health of its embassy staff. Namely, we're installing high-quality air quality monitoring equipment in U.S. embassies in 24 cities and 14 countries during the coming year. These are going to provide real-time data to employees at the U.S. embassies so they can make decisions that protect their own and their family's health. For example, if air pollution is really bad, some may choose to have their kids skip soccer practice on a particular day, or football, as it's called in most of the world. The data will be hosted on the EPA's Air Now platform and made publicly available through a new site called DOS Air. That stands for Department of State. We expect to roll out the data in just a few days. We'll be including not only the raw mass concentration data, but also hourly PM 2.5 air quality index data. This is in line with the President Obama's Open Data Initiative, helping information be easily available to consumers, by the public, and available to host governments, scientific community, and to citizens. I want now, next slide, to turn to a quick overview of what we call the SLCP toolkit. This was created as part of our work, sorry, go back one. This is created as part of our work with the Climate and Clean Air Coalition, which was formed in 2012. CCAC now has over 100 members, about half of them nations, with the rest being civil society and intergovernmental groups. One of the coalition's initiatives is called Supporting National Action Planning, or SNAP, and the toolkit is an integral part of that. I don't want to get too much into the weeds on the toolkit. The headline is basically that it's designed to allow countries to get a better handle on the range of benefits that come from reducing methane and black carbon in terms of health and climate and agriculture. Specifically, and now can we go to the next slide? No, back one. The toolkit is designed to allow countries to characterize national and/or urban emissions, to explore alternative emission scenarios, to calculate country-level health, agricultural, and regional climate benefits, to compare results across alternate scenarios, and to support national and city-scale policies that reduce SLCPs. This graphic shows the benefits estimated for implementation of SLCP mitigation measures. Each bubble corresponds to a country, and the size represents the relative magnitude of the benefits. Next slide, please. So there's two primary components in the SLCP toolkit: LEAP Integrated Benefits Calculator, which has both an emissions and scenario module and a simplified benefits estimation module, and then Benamap Community Edition, which estimates the economic value of health outcomes. Next slide, please. In the emissions and scenario module, users can build SLCP relevant models and implement hypothetical control strategies. Then, based on default emission factors that are linked with specific activity data, those can be changed if the user has more specific data available. And it also involves use of gross domestic product, population, and other drivers that then are folded into development of the emission scenarios. This screenshot shows what happens where users can update emissions about fuels that are used for cooking. It's just one example of the data that can be modified within LEAP IBC. And the screenshot here shows the avoided black carbon emissions with the dashed lines at the very top of each bar, estimated from implementing an improved cook stoves policy. Next slide, please. This screenshot shows projected differences in premature mortality from a hypothetical SLCP mitigation policy. The orange is the baseline and the tan is the policy. This links the emissions from LEAP or other sources to a global air quality model to estimate concentrations of particulate matter and ozone pollution, and estimates benefits using concentration response relationships for health and climate and crops. And the Benamap component, again, allows users to input more detailed data if they have it available. Otherwise, it is preloaded with data from the Global Burden of Disease study for each country, including modeled air quality, population, baseline mortality, and integrated exposure response functions. As I mentioned, again, if you've got more specific data than that default, you can easily insert it. This also calculates health impacts and monetized benefits for ozone and PM 2.5 air quality data. Other key partners in the development of the toolkit are the Stockholm Environment Institute and the University of Colorado. SEI developed LEAP, and Dr. Henze is responsible for, at the University of Colorado, is responsible for the air quality modeling underlying the benefits calculations. The real experts on this, not surprisingly, are not found at the State Department. Rather, there are colleagues at the U.S. Environmental Protection Agency whose names are given here on this final slide. And with that, let's go to Q&A.
Thanks, Karen. Please stay and take your seat. And thanks. What good data we have that can help inform not only what we're doing to fight particulate matter, but how the health benefits that has, and we can do so on a day-to-day basis. And you put a lot of this in the context of the Climate and Clean Air Coalition. I did want to call out because one of our key partners in that is WHO, and Maria Nera, who's responsible for that, is in the audience here. So thanks, Maria, for being here. We do have time for questions and answers. We have time for questions, and I'm sure we have the capacity for answers. So Ashley has a microphone, and please recognize them.
Hi, thank you. I'm Karina Hers from the Population and Sustainability Network. We're a London-based alliance of civil society organizations working on the linkages between health and the environment. So I'd like to thank the U.S. Department of State for convening an event that brings together the health dimension with the climate change dimension, which is, I think, largely lacking in these discussions. Also, I'd like to congratulate the USAID, because I don't know if you are familiar with their population health and environment programs, which are aid programs being delivered around the world that are linking population health and environment interventions for improved health, livelihood, and environment impacts around the world. And I think not only are these very effective in climate change adaptation and mitigation, but also in the larger context of the SDGs. So I think I'd like to make a call here today that USAID maybe speak to other donor countries and work with them to also integrate such, to promote such integrated funding streams in their work around the world. Thank you.
Okay, let's take a question.
Thank you very much. I am Maria Neira from the organization, and I would like to congratulate you very much for organizing this event. We cannot agree more with you, so we don't have even questions because we fully partnered with you. Maybe just one thing. In May this year, as you well know, because the US has been supporting very much, an historical resolution was approved on air quality and health. And that gives us an enormous task now to mobilize very strongly the ministries of health, because they have very much to be part of this. And this will be my question to you. How can it be possible that when we have such a very strong arguments that the ones you were presenting on the gains for public health and reducing air pollution, which is responsible for killing 7 million people every year, how can it be possible that we are not signing now? We don't need to wait until the 11th, but signing now immediately. Do we need to move for something like clean air, as the United States did some time ago, and saying, well, if you don't do it for the planet, do it for the health of the people, do it for health. And a question for the colleagues on working on the healthy hospitals and greening in the hospitals. Apart from the reducing the environmental footprint, are you detecting as well a motivation coming from the fact that this is contributing to the health of the people, this is a more efficient use of the resources at the hospital level, and this is generating as well decrease on the cost for the healthcare facilities? And thank you again. Thank you, John, as well, for organizing it.
One of the critical reasons to do the toolkit is oftentimes having specific numbers around specific locations within the jurisdictions of particular policymakers helps incentivize policymakers to take action. Something that's out there is a sort of general construct, like the relationship between health and climate, becomes a lot more action incentivizing if you run the numbers and seen how many of your citizens are at risk of premature mortality and premature death and of illness. That's one of the reasons that we think this toolkit is so important.
Maria, Dr. Nair, thank you very much for the question. Just a couple of thoughts in addition to what Karen has said about how do we get to the health ministries and to the health ministers. One of the challenges in environmental health in general, of course, is that the implementation of the prevention steps is outside of the control of the health ministries. And so often the health ministries haven't traditionally seen it as part of their role. I was very pleased to be part of a State Department-led effort with EPA teachers, actually, to train health ministry personnel in the ASEAN countries around, in the Southern Pacific area, Southeastern Asia, on how to use these tools and how to generate this. I think there's a lot of outreach and training that needs to happen. I also think that the SDGs, as they come in, will provide us with the kind of indicators and platforms to start measuring and start increasing the accountability of governments to attain some of these goals. And I think that will also be helpful to getting the health ministries involved.
I'll just add one more thing. One of the reasons that the U.S. co-sponsored and was driving this resolution, the World Health Assembly, on air pollution and health, is that the WHO really can play a key role with many of the country representatives from WHO embedded in health ministries to look at air pollution not just as a problem in other sectors, but one that has health consequences, and to look at health outlays to improve health, not just as expenditures or drain on budget, but actually good investments that'll save the society money in the long run. So I think WHO's role in that can be reinforced by that political mandate from the member states.
Well, I of course, will be impossible for me to teach you anything, Maria, but you know this very well. But for the rest of the audience, I think one of the keys for us was to understand that in a group like this, we all get it and it makes sense, and it's crazy that other people just don't fall in line. But when we looked across our region and my board and the businesses, there was a huge variety in priorities in their mind on what was most important. And so for some groups, we focused really hard on the health of the community and said, this is for the asthmatics and the lung disease patients and the heart disease patients. Or we focused on women and children and cited the 100 chemicals that are found in cord blood all the time, so we have to manage our wastes. For others, they had a different approach, and they felt more strongly about the economics of it and said, how are you going to do this that is economically sound for the healthcare organization? We don't want to pay more for our healthcare, so we showed that we could lower the cost of healthcare and do this right. And then for others, it was the whole region. How can you help the region economically while you're doing this? So we built a case so that regardless of the audience, we could show in hard numbers and in emotional stories that we were heading in the right direction. And I think this is the advantage of tying together the global initiatives, the things the World Health Organization have done, because there are many examples. What worked in La Crosse, Wisconsin at Gunderson isn't necessarily going to work in every place in the world. So the collection of the stories, the collection of the multiple approaches is how we're going to move this more quickly on a broader scale. Thanks for being here.
Great, and I actually have a question from online, and then we can take one from the crowd. This question is from Patricia Juarez, and she asks, I think this is in relation to the Healthy Hospitals Initiative as well, how did you deal directly with the energy producers when changing to green energy options? So that's one question, and let's take one over here. Let's just take one more, if that's okay.
Oh, you want to put them together? Yeah. Okay. My name is Peter Orris. I'm a physician at the University of Illinois Hospital and Health Sciences System in Chicago. And I was a little surprised with the initial announcement that this was the only health session being done here at the U.S. Center for this session. Hopefully next time we'll have many more sessions on health, as it is the linchpin, as you have told us about many of these discussions. Of course, we salute Gunderson and the leadership of NIEHS and the government. I have a question about, and it may be a little too detailed and outside of the area of the State Department. I have the pleasure of serving on the Illinois State Department of Health, and we're quite concerned about methane coming from hydraulic fracturing. And I'm wondering, I couldn't tell from the slide whether the method used to generate energy was isolatable from those databases. And I know, although sometimes we think we need the State Department between Washington and Illinois, I know it's not your area, but that would be very interesting to us if that's available. Thank you.
Should I maybe do a quick answer to that second question, which is that what's in there is information on based off of methane concentrations, not on the source of the methane.
And so for the part on working with the power companies, it's going to sound like my other answer. It really varies depending on the power companies. But we set out to generate our own renewable energy because we wanted to keep the costs down. And we used multiple methods. We used dairy biogas, landfill biogas, wind, biomass from hardwood chips from our region, so this is a more regional approach to it, conservation, a geothermal field, and it is true, depending on the power company, as we interact with the grid, we get a more favorable or a less favorable contract with them. So that is an ongoing struggle as they see large players. We're a billion-dollar organization with a pretty big energy appetite, less than before, but pretty big, look to generate our own power, but still stay connected to the grid for the ups and downs. I would say, and a shout out to our people working on this, for the months of October and November, we produced more renewable energy than we used across this billion-dollar system. So that is the first time we've ever made it that long a period. So that's pretty remarkable. Thank you. And has much less of an impact from CO2 and particulate matter.
Good. We just have 3 or 4 minutes left, but there's time for 1 or 2 quick questions.
Hello, my name is Mariah Correa. I'm a student at McAllister College, so over close by. I'd like to ask, how are you preventing health and climate action from being siloed? Whether that be working with the Department of Agriculture, Ministries of Finance, etc.
Hi, thank you for this panel. My name is Harleen. I work in Washington, D.C. in healthcare policy. Just graduated from USC in May, and I'm planning to go to medical school in a few years. And I was just wondering, in conversations with my peers talking about my work in climate change, and I was brought into this space really from a public health background. What are your recommendations for the next generation of healthcare leaders, of physicians? How can we keep this conversation going after the COP, and how can we generate interest in demystifying the relationship between healthcare and climate change? Thank you.
So the first question is an always challenging question, which is within any government or international organization, how do you avoid the siloing? And I don't have the simple answer to that question, but I would point to the work that we're doing within the U.S. Global Change Research Program. I co-chair, along with leaders from the CDC and no other National Oceanographic Atmospheric Administration, an interagency working group on climate change and health that very explicitly involves members from the Department of Agriculture, from our State Department, from the EPA, from all of the different agencies that we can get to participate. That's one model by which you can start to work across those silos. There are lots of examples at a state and local level. Sometimes it's a little bit easier. At those levels, sometimes it's a little bit harder. I think that the short answer to the question that it often involves a lot of leadership on the part of one of those sectors to really reach out and engage the other sectors. From the stories that I've heard, that's often the way it ends up happening.
Just one other example on that is do things together. So for example, EPA is very, very engaged with the State Department in work relating through the Climate and Clean Air Coalition. So it's sort of the actual on the ground of working together on particular issues, I think, particular topics, that is a particularly effective way to break through the silos.
And for your question, with the next generation coming up, there are tons of opportunities. It is it is one of our recruiting advantages at Gunderson to have our sustainability program be so successful. We have people applying for work at our place because of that. You can stay connected. The Healthy Hospital Initiative that I mentioned has 1,500 hospitals and health systems in it. We have free online activity that happens, Practice Green Health, Healthcare Without Harm, in the world scene, the World Health Organization. There are many opportunities to get in the door. IHI, the largest quality improvement organization in the world, has a forum every year, but it has an open school that talks about environmental issues. We'll present at the National Forum this year. So there are many opportunities for healthcare to be active in this space and actually lead. We've been following for a while. We need to lead. That's our responsibility.
That's eloquent, and it's going to be hard to top that as a final word, but this really is something I hope can be one of the legacies of the Obama administration and our work at the Department of Health and Human Services. HHS is a global actor, but we don't behave like one. Our thinking and our culture and our systems don't reflect the fact that there's a tidal wave of people like you, not just in the United States, but in many countries around the world who want international careers and especially global health careers. And finding a career track for those people so that whatever you're doing, whether you're working in La Crosse, Wisconsin, or you're actually in the USAID mission overseas working on health and population and environment as a joint project, that you feel you're part of a community which communicates, which has people in other countries and other governments who are thinking the same thoughts and with whom you have a bond and a common purpose. And within the government, State Department has really emphasized global health diplomacy. We're hoping that in HHS we're looking at our international role in a much more creative way. And that is in part to attract the very people like yourselves who are the next generation of global health leaders, but for whom there aren't these clear entry points and landing zones, how to come in and out of government, how to come in and out of international work and go back to home communities in the United States. So thanks for bringing that up.
And then one final point on that, if I could, is that a lot of integration of health and climate occurs in the U.S. context domestically as well as in our international work, such as through the Climate and Clean Air Coalition. And I just want to close with a little plug for the fact that there will be a specific, right here in this very space, EPA Administrator Gina McCarthy will be talking about her agency's pioneering and incredibly effective work to simultaneously be addressing both of those issues, and that is December 8th at 12:45. Be here or be square.
We have many final words. I just wanted to add one more aspect of this, which is the education and training issue. And one of the aspects of the President's Health Summit, one of the developments that was announced back at the Climate and Health Summit in April was the commitment at that time of around 70 schools of medicine, public health, veterinary medicine to include climate change into their curriculum. That number is increasing. This is still an area of great interest to the White House to get the schools to start committing. And I think that in accordance with Ambassador Kolker's point, it's not about making sure that the environmental health courses have a discussion of climate change, because they pretty much all do. It's really about the global health course. It's about the infectious disease epidemiology courses. It's about mainstreaming the issues that climate change is very important to throughout the spectrum of health education. And that's what these schools are committing to do. That's what we'll be working with them on. Thank you.
Perfect. Okay. Fantastic. Thanks to all of you, and thanks, Karen, for reminding me, because I think I was made some enemies here by saying this was our only health event. In fact, Gina McCarthy's event next Tuesday can also be considered a health event because of the great work that the Clean Power Plan promises to do for health in the U.S. And go ahead and pick up one of these schedules so you can check out that event and others. I believe that event is at 12:30, so if you come at 12:45, you might be a bit late. So please come at 12:30. Sorry if that changed in your points there. And also, thanks so much for our online audience. I understand we had some viewing parties joining us, perhaps from HHS. So thanks so much for joining us there. And thanks to all of you, and we look forward to seeing you the rest of the 2 weeks.